Director of POG. Furthermore, all the other experts en alle collega's in de zorg hier op de webinar.
He's switching, and that's a bit problematic. He should speak one language. Because for the recording, we will have a problem then. He's switching from Dutch to English.
Ik kan doorgaan in het Nederlands. Oké, ik
Nederlands.
in het Nederlands.
Okay, he will continue in Dutch.
Ik wil een ieder.
I would like to thank everyone
voor de aanwezigheid vandaag.
For their presence here today.
Maar voornamelijk de PAHO.
But especially the PAHO.
Heel snel ondersteund heeft.
Quickly supported us.
Van zo'n webinar.
With organizing such a webinar.
Sinds 14 januari.
And since the 14th of January. The central lab
positieve testen
again confirmed positive
van chikungunya.
Cases of chikungunya.
En hierna een aantal andere positieve.
Also other positive cases.
Is dit doorgegeven aan het ministerie.
And this was
kleine werkgroep opgesteld.
The ministry was informed about this, so I set up a small working group.
En de minister heeft Dr. Maureen.
And the minister also took care of the funding.
En Dr. Maureen Wijngaarden van
And Dr. Maureen Wijngaarden.
De trekker van deze werkgroep. Zij heeft
is in fact the one who's in charge of this working group. She also helped to organize the webinar.
En ondanks het feit dat we.
And despite the fact that we already know a lot about chikungunya.
Is het nodig.
It is necessary at such moments to do a refreshment.
En hier gaan we dan
aandacht
besteden aan.
That we're going to pay attention to the diagnosis and the management of chikungunya. And that we also get guidelines of how to deal with it in practice.
Dus de sprekers
The speaker, the previous speaker has indicated
dat u toch nog na zo'n zware
that you still, after such a working day,
deze webinar bijwoont.
You took your time to attend this webinar. We really appreciate that.
En ik wens jullie
and I wish all of you
leerrijke
a very educational
webinar. En ik wil
And I would like to once again thank the PAHO and all the experts for their contribution.
En niet te vergeten, jullie als participanten.
And of course, you participants who will have to help us
van deze epidemie,
to manage this outbreak.
Dank u wel.
Thank you.
Thank you very much, Director Dr. Suko. And this is now my pleasure to introduce Dr. Cleaver Luz. Originally from Brazil, Dr. Luz is a pediatrician and infectious disease specialist with more than 20 years of experience in clinical diagnosis and management of infectious diseases. He is an associate professor in the Department of Infectious Disease at the Institute of Tropical Medicine, Federal University of Rio Grande do Norte, Brazil. In addition, he is a member of the WHO Technical Advisory Group on arboviruses and member of Pan American Health Organization International Technical Expert Group on arboviruses, where he supports capacity building activities, development of clinical guidelines, and evaluation process for national arboviral disease prevention and control program. Welcome, Dr. Luz. Floor is yours.
Thanks for the words. Good afternoon, everyone. It's a pleasure for me to stay with you. And thanks for Parho for the invitation. Diego, would you share the screen? Okay, next one. Okay, at the beginning, it's important to understand how to understand a clinical case. Of course, you know that sometimes it's a little bit difficult to do the diagnosis in a febrile patient, maybe a pediatrician patient, an adult patient, or an old patient. So, for understand the disease, it's very important to identify first the chronology of the symptoms, especially in arboviral disease. For example, if the patient begins with rash and fever, probably at the first day of the symptoms, this is a Zika virus disease. But if the patient at the first day of disease had high fever, joint pains, and the rash begins at the day 3 or 4 of the disease, may be Chikungunya disease. And if the patient begins with fever, myalgia, arthralgia, and at the day 4 or 50, the patients develop an important abdominal pain, probably maybe a severe dengue case. So it's important because sometimes we understand the tropical disease, especially the arboviral disease, like a disease that we can find in the patient's fever, myalgia, and arthralgia. So it's important to ask the patient the chronology of the symptoms. If he is a pediatrician patient, we have to ask the mother or the grandmother about the chronology of the symptoms. It's very important for the physician and, of course, for the nurses, especially in the primary care, to understand the pathogenesis and the physiopathology of the signs and symptoms. Why the patients develop a fever, why the patients develop joint pains or arthralgias. After this, it's important to establish the diagnosis of the patient. What is the diagnosis? The diagnosis is the name of the disease that explain the patient's signs and symptoms. So, if the patient has fever and headache, headache is not the diagnosis of the patient. Arbovirosis is not the diagnosis of the patient because arbovirosis means a mechanism of transmission of the virus. Of course, the virus that are transmitted by an arthropathy. So, of course, we see uh, some patients that the diagnosis dengue A, dengue B, dengue C. This is not the diagnosis. Dengue A, B, or C is the therapeutic proposal for the patient. So the diagnosis is always the name of the disease that explain the patient's signs and symptoms. And all the doctors at the end of a consultation have to do, must do the diagnosis of the patients. So have to choose the diagnosis: influenza, is dengue, is chikungunya, is meningitis. Of course, we have to choose the diagnosis of the patients. Next, Diego. So it's very important to understand the chronology of the symptoms and the signs because we have to understand which phase the patient is. Generally, the infectious disease or, of course, tropical disease have distinctive phase. And you have to understand in which phase the patient is found. It's so important. For example, if the patient has dengue, it's important to understand if the patient is in the febrile phase, in critical phase, or in recovery phase, because the intervention, the medical intervention, depends about what phase the patient is. If the patient is in the febrile phase, of course, we have to treat the fever. We have to hydrate the patient. But if the patient is in a critical phase, we have to use a lot of fluids to recover the patient because during this phase, the patient may develop a shock. So it's quite different to treat, to do the intervention in a dengue patient if the patient is in critical phase or in febrile phase. Of course, if the patient's in the recovery phase, we have to use the liquids and pay attention and overflow that the patient may develop if you do not control the IV fluids. It's very important to investigate and to understand the presence of comorbidities because if the patient has a comorbidity and develop an infectious disease, especially an arboviral disease, what's happened? The patient has diabetes and develop chikungunya. So the diabetes probably interfere in chikungunya and the patient may develop a chikungunya more severe. And the chikungunya interfere in diabetes and the patient may have hyperglycemia, for example. So if the patient has two diseases and diabetes, hypertension, for example, and develop chikungunya, we have to look for these two diseases because the severity of the patient may be more expressive if they have two or three comorbidities, especially in the old population. And you know, in the South America, that we have a lot of old people living in our countries. And at the end, we have to identify the category of intervention. The intervention is what we are going to do with this patient. We will treat this patient like an outpatient, or we have to refer this patient for a hospital, for an intensive care unit, for example. So at the end of the consultation, all this data have to be clear for the physician, for the nurses, for the team, for the health team that are treating this patient, and of course for the patient and for the family. So the the team have to explain for the patient, for the family, what to do and what and where the patient have to be treated and when the patient have to come back to the health service to see a doctor again. For example, if a patient has a Chagas cardiomyopathy, it is in the chronic phase and the functional class is 4, so the patient's very severe. And if the patient has a insulin-dependent diabetes, so, what is the intervention category? The intervention category is that this patient have to be admitted in ICE intensive care unit, of course, in the hospital. If the patient has Chagas disease but is in chronic phase with no important organ damage, this patient may be treated and followed like an outpatient. So it's very important to understand this and to organize the health system in primary care and secondary care, tertiary care. Of course, the people who live at the Suriname knows about the health system and know how to organize and how to refer the patients for the health system. Next slide, please. Let's begin to talk about the chikungunya. Chikungunya is an old disease. We can say this. Chikungunya was present in Africa and probably during many years. But it's important to understand that the virus that causes chikungunya is an RNA virus. And we know that the RNA virus can suffer mutation. And probably this occur with the chikungunya virus, and this mutation increase the adaptation of the virus to the mosquitoes and facilitated the transmission in Africa and South America and in Asia. In the past 50 years, outbreak has occurred in Africa and Asia, and the disease was restricted to these two continents. But after 2013, the virus arrived to Caribbean island. Caribbean island, of course, is close to Surinam, and probably the virus has a chance to occur in Suriname, like in Guyana, like in Brazil, and you have a lot of outbreaks in South America. Here, where I live in Brazil, in northeast of Brazil, now we have an increase in the number of cases of chikungunya. So the Asian genotype is present in Caribbean and in other parts of Brazil. Next slide, please. It's important to understand that chikungunya is transmitted by mosquitoes. So if you have 20 cases of chikungunya in the community, of course, you found the mosquitoes. And the mosquitoes, we have two species of mosquitoes. We have Aedes aegypti and Aedes albopictus. It's important to understand that if you have chikungunya case in the community, we can see during a chikungunya outbreak dengue cases and Zika case. Why? Because the Aedes aegypti and Aedes albopictus may transmit Zika and dengue. In generally, when we have a chikungunya outbreak, the majority of cases are caused by chikungunya virus. But it's important to pay attention because if you have a lot of patients with chikungunya, maybe 1-2% of the cases with dengue. And of course, everybody knows that dengue is the more severe disease, more severe arboviral disease, because the patient may die at the day 3, 4, or 5 when the patient develops shock. And the Aedes albopictus and the Aedes aegypti is found in all the Americas, in Caribbean, South America, Central America, including North America. Of course, the majority of mosquitoes are present in Central America and in South America. But we have a lot of cases of arboviral disease in Mexico and during the last year. And what's happening with these mosquitoes? They feed during the daytime, quite different from other mosquitoes that feed during the night. The mosquitoes Aedes feed during the day. So it's easy to identify these mosquitoes because these mosquitoes have characteristic signs like we see in this picture in the screen. Next slide, please, Diego. Now we see the chikungunya distribution of the clinical case in the world. So we see the chikungunya is present in Asia, in Africa, in North and Caribbean and South America. So the disease is important for us that we live in this area, but it's important for the tourists that come from North America, from US, or coming from Europe. But now, in the last year, in 2025, the local transmission of chikungunya occurred in Europe, But of course, it's important to inform the tourists that if they come to South America, for example, come to visit Suriname, and we saw the pictures from Suriname as a very beautiful country, and the tourists may acquire chikungunya and develop the disease at Europe, for example. So it's important to inform the tourists how to protect it against the chikungunya disease. Next slide, please. It's important for the doctors, especially, to understand why the virus spread in the body. It's a little bit different from dengue because when the mosquito bite the skin with dengue virus, the virus reproduce in the skin, have a dissemination for a ganglion, and after this, the virus go inside the blood and affect the organs and the vessels. In chikungunya, the Aedes albopictus may introduce the virus directly in the blood. So we expect that the viremia in chikungunya patients may be higher than the viremia in dengue or in Zika patients. It's why the patients that develop chikungunya probably will develop a fever, a high fever, if we compare with dengue. Of course, sometimes it's difficult to understand this because the patient with dengue may have a high fever and the patient with chikungunya may have a high fever, but we expect that the patients with chikungunya may have high fever than the patient with dengue, but especially the patients with Zika, because in Zika, the viremia is not high. So the virus infected the dermal fibroblasts, and after this, infected the white cells from the immunological system and go to lymph nodes and disseminates. During this dissemination, the virus affected the immunological system, the natural immunological system, and activate the immunological system. So begins an important production of cytokines. So the cytokines may affect the body with fever, with ache, etc. So chikungunya is a disease that we can find the virus in the blood, but we can find the virus in muscle cells, in the brain, in the spleen, in the liver, but especially in the joints. This is the most important characteristic of the disease is the joint compromise that occur in the chikungunya disease. Of course, in a patient with dengue, we can find joint pains, we can find arthralgia, but in generally, the patient do not have edema or joint inflammation. So the virus go inside the joints and activate the immunological system, the innate immunological system, and we can find neutrophils, macrophages activated and produce an important amount of cytokines inside the joints. Next slide, please. Of course, this is a little bit the same of the anterior picture, anterior slides, but we can understand that the virus introduced by the mosquitoes go to the muscle, so produce an important muscle pain, and all the tissues from the joint are affected by the chikungunya virus. So the synovial sites, the synovial membrane, the, we can find an infiltrator in sinusites. So the patient have the joint pains. And if you look for the joint pains, probably you will find the edema and sometimes the joint is red and sometimes the joint is hot. So sometimes the joint cannot move naturally. So the patient can't move the joint. So it's difficult for the patients to walk. Remember that the patient with dengue may have a muscle pain, but it's not difficult for the patient with dengue to walk. If the patient has chikungunya, it's difficult to walk because all the joints are affected and it's difficult to walk. So it's important. And the virus inside the joint activated the immunological system, and probably the RNA of the virus may activate the immunological system for 1 week, 2 weeks, 3 weeks, 2, 3 months, and sometimes for years. So chikungunya is an arboviral disease that have an acute phase, but the patient may be sick for months or years. So it's an arboviral disease that may affect the patient like a chronic disease. And of course, if you have an immunological activation inside the joints, this activation may destroy the cartilage tissues in the patient. And this compromise of the cartilage tissue may produce sequela in the patient. The sequela may be for forever, and the patient may have a sequela and impact in the health system of the country. Next slide, please. So, the resume of the pathogenesis. So, the fever is related to the viremia. Of course, in generally, the fever usually lasts about 1 week. Probably 100% or 9% of the patients have fever. It's almost impossible to find a patient with chikungunya without fever. But if you collect the blood for molecular tests, you can find a patient with a molecular test positive for chikungunya virus, and the patient may not have the fever. But it's difficult to find a patient with chikungunya without fever. What does it mean? It means that in Suriname, if you have now a chikungunya outbreak, all the patients that you see, especially in the primary care, with 1, 2, 3 days of fever, you must think in chikungunya, especially if the patient has arthralgias, especially if the patient has polyarthralgia. Of course, you have to do the differential diagnosis with dengue, with other disease, infectious disease. But when we found a chikungunya outbreak, probably in a small city, a lot of patients will develop the disease during 3, 4 months in the year. And if you found an outbreak, a small outbreak in Suriname, probably in the next week, we will see a lot of patients. All the patients develop arthralgia. The arthralgia is characteristic in chikungunya patients. If you have arthralgia in left side, you can find arthralgia in the right side of the patients. And polyarthralgia means that 5 or more joints are affected. So if you see a patient with monoarthritis, probably it's not a chikungunya case, because in chikungunya case, all the patients develop polyarthralgia. And the rash is frequently about 40 or 50 patients of the patients may develop a rash, and it's about during the first week. So, in review, the viremia is present at the beginning of the disease. Usually, the viremia is present during the first 5 to 7 days. After the viremia, the adaptive immunological system produces the antibodies. The antibody produced against the chikungunya virus are from two classes, like in other diseases. The first one is the IgM. So the patient may have the IgM production probably in the first week of the disease, the first week after the beginning of the symptoms, and persist for 1 to 3 months. But sometimes the patients may have IgM detectable during the 1 year, 2 until 3 years. So it's difficult to use the IgM to confirm the chikungunya diagnosis in the patients. Why? Because if the patient has chikungunya during this week in January 2026 and develop other febrile disease with arthralgia in 2027, the IgM against chikungunya may be present. So it's important if you have to do the diagnosis of the chikungunya. Of course, we have to use the epidemiological data. We have to use the clinical data, the chronology of the symptoms, but it's better to confirm the lab diagnosis of chikungunya using molecular tests. Because if the patient has a viremia detected by molecular tests, of course, we confirm the chikungunya case. Of course, the IgG is detectable about the end of the first week of the disease and persists for years. And the IgG is not useful to do the laboratorial diagnosis of chikungunya in the community. And the patient may be sick for weeks to months and for years. Next slide, please. So we have discussed something about the clinical symptoms of chikungunya, and now we will have a revision, and we will show some pictures of the patients from Brazil that we found here where I live, or from Bahia, from Dr. Melissa. And of course, we have some pictures from patients from Dominican Republic in Caribbean. And so the infection caused by chikungunya virus in general is a symptomatic infection, distinctly from Zika virus, that the majority of patients infected by Zika virus may be asymptomatic. We think that 8% of the patients infected with Zika virus may be asymptomatic. And in chikungunya, about 7 or 80% of the patient may develop symptoms. The incubation period is like the other disease, arbovirus disease, is about 3 to 7 days. But of course, if the patient visiting a chikungunya transmission area and do not develop the disease after 2 weeks, probably this patient will not develop the disease after 2 weeks. The viremia is about 10 days, but sometimes if you collect the blood for a molecular test, we can find the virus or the RNA of the virus after the day 10, 2 or 3 weeks. And it's important, we comment at the beginning of the presentation about the phases of an infectious disease or a tropical disease. And it's important to understand that in dengue we have the febrile phase, critical phase, and recovery phase. And in chikungunya, we have an acute phase, post-acute phase, and chronic phase. How many days is the acute phase? It's until the day 14. What's happened in the acute phase? All the symptomatic patients, of course, has a high fever. And if the patient has a comorbidity, the comorbidity may be decompensated. So, during the acute phase of chikungunya, in all patients, we have to look for the chikungunya disease and for the comorbidity. So, what is the lab for care a patient with the chikungunya? The lab, of course, is collect a blood sample for RT-PCR for chikungunya, but you have to collect a blood sample for the glycemia in a diabetic patient, for detecting the kidney function if the patient has a medical history of kidney failure, for example. And what's happened in the acute phase? If the patient is in the acute phase, may decompensate the comorbidity and may have a severe disease and may have an evolution for the death. So it's important to understand this. In the post-acute phase, it's a phase between the day 14 until the day 90, and especially the patient improve week by week. But during this phase, the patient may develop a skin manifestation of chikungunya virus. In the skin manifestation, like bolos, the skin manifestation may be severe, and the patient, of course, it's not frequently, may have a severe evolution during this phase. After 3 months, the patient is in the chronic phase. What's happened in the chronic phase? The patient has joint pains, and sometimes it's so difficult to treat this chronic phase, the joint pains during the chronic phase. And we have a low case fatality rate, 1 per 1,000 patients, but sometimes the patient who have the evolution for death is a newborn patient or the children under 1 year of life. Next slide, please. And more details in the acute phase. The fever is high. We can find a sudden onset, quite different from the other disease, that the fever is increasing day by day. In the chikungunya, the fever begins in about 39 centigrades and may be present for 1 until 7 days. And what's happened with the joint pains? About 90% of the patient has joint pains. And usually the joint pains, the polyarthralgia, is symmetric at the left and at the high side. And the polyarthralgia involves the large and small joints, with the distal joints most frequently affected. We had commented about the screen rash, and especially the rash may affect the trunk, the extremities, the face, and palmar and the plantar region. And the rash may be a diffuse erythema that blames on pressure, but the patient may develop a lot of kinds of rash like erythema nodoso or an exfoliative dermatitis. So, if we found a patient with a rash, a skin rash, we have to ask what's happened in the last 3 or 2 weeks. Did you have fever? Did you have joint pains? Because if the patient may look for the doctor consultation only with the rash and do not remember about the joint pains. Next slide, please. Of course, we can find all kinds of symptoms or signals during the acute phase, like myalgia, headache, asthenia, no purulent conjunctivitis, but of course, conjunctivitis, no purulent conjunctivitis is more frequently in the Zika patients. But like in dengue, we can find a retroorbital pain, chills, it's important, and frequent chills, nausea and vomiting, diarrhea, abdominal pain, and especially a lymphadenopathy. Lymphadenopathy, if you look in the literature, may be present in the dengue patients. But I think that in Suriname, you have a high experience in managing dengue patients. and it's not frequently to found lymphadenopathy. But in chikungunya, we can find lymphadenopathy frequently in all the patients, adult patients, old patients, and in child. And it's important that chikungunya is a disease that compromises the skin, but the mucosa may be affected by the virus, and we can find the oral ulcers in these patients, especially in the second week of the disease. But in general, the patient after the second week improve, and at the end of the month, the patient will be okay. Next slide, please. In the post-acute and chronic phase, what's happening with the patient? Is the pain the most important clinical sign or clinical symptom in the patient? During the post-acute phase or chronic phase, the other symptoms disappear and the patient may have only the joint pains. It's more frequently in the patients over 45 years old and female sex, and especially if the patient has a history of joint disorder. And if the patient may have a severity of joint involvement during the acute phase, it's probably that this patient may have an important chronic phase. And the symptom may persist up to 6 years, 5 years. So the health system may be prepared, have to be prepared to treat this patient and organize, because sometimes the patients need the primary care doctor, but sometimes the patient needs a specialist like a rheumatology for treating the joint compromise during the chronic phase. Next slide, please. We will show some pictures of the patients, the dermatological manifestation. Sometimes we have to press the skin to see more clear the rash in the patient, especially if the patient has uh, black skin. It's sometimes difficult to identify the rash, so have to use your hands to examine the skin of the patient to find the papulas in the skin of the patient. If you do a chikungunya consultation, you have to have a good light to find the skin manifestation. Next slide, please. The rash may be different in some patients. We found the plaque in these patients. Next slide. The rash is bilateral in the palms of the hands. Next slide, please. Erythema, it may be present, like you have to do the differential diagnosis with erysipelas, skin infection caused by streptococcal disease. Next slide, please. In the hands, it's important to look for the hands. Next slide, please. In the feet of the patient, we can find the descamation in this patient. Next slide. Probably maybe at the third week of the disease. And of course, we found the joint pains in the patient. We see in this woman a bilateral compromission of the joints. We found edema. We found the limitation of the movements of the hand of these patients. Next slide. The joint manifestation, edema, is generally bilateral. Next slide, please. Edema bilateral. Next slide, please. And conjunctivitis is not a purulent conjunctivitis. It's like that we found in Zika patients, but it's not so frequently. Next slide. It's important to understand the chikungunya in the pregnant woman. because if the patient is close to the labor time, the virus, the chikungunya virus, may be transmitted for the newborn. And this transmission, the transplacental transmission, may occur in about 50% of the pregnant woman. And if the newborn become infected with the chikungunya virus, probably this newborn may develop a severe disease, and is a disease that the clinical manifestation is quite different from the patients, an adult or an old children. Chikungunya in the newborn period, we will show some pictures of the patients, is like a sepsis, and probably this newborn have to be admitted in the newborn intensive care unit. And we don't know, we know that the newborn intensive care unit is not present in small cities in South America. And it's important to understand that the type of deliveries do not alter the transmission rate. And chikungunya is not present in the breast milk, so the the newborn can use the breast milk for the nutrition. And it's important to monitoring all the pregnant women with chikungunya. So if the pregnant woman develop a fever, especially with joint pains, probably it is a chikungunya case, and you have to monitor this pregnancy every day. Every day, this pregnant woman have to go to the health system to be consulted by a doctor or a nurse to understand what's happened with this patient. Next slide, please. This is the dermatological manifestation of pregnant woman. Next slide. Of course, we have commented the chikungunya in the newborn. We can find the severe manifestation. The vertical transmission is considered when the symptoms occur during the first week of life. Of course, what's happened with the newborns? If the mother had chikungunya during the labor, the newborn have to stay in the hospital until the day 7 or the day 5. Of course, each health system have to choose how many days the newborn have to stay in the hospital for a close observation, for a close monitoring of the clinical signs of transplacental transmission of the chikungunya virus. Of course, we have to collect the blood samples for this newborn, send the blood sample for the lab, and look for the molecular test if the molecular test was positive or negative for chikungunya virus. And it's important to know that the central nervous system involvement is severe and is frequent in about 30% of the patients. But in Paraguay, what's happened with the newborn? Some newborns develop hypovolemia with shock. So we know about dengue. We know that in dengue we can find the shock, but in chikungunya the shock was not frequently. But during an important outbreak in Paraguay country, they found that a lot of newborns developed a shock, and the shock was a cardiac shock or distributive shock. We don't know what is the kind, especially in the newborn, but you have to look the newborn for central nervous system involvement or shock. So you have to monitor the blood pressure of all newborns that born from a pregnant woman that had chikungunya during the labor. Next slide, please. Uh, this is the manifestation, clinical manifestation in the newborn. Of course, they have fever because we know that in chikungunya all the patient has fever, joint edema, but in general the newborn develop lethargy, irritability, and a frequent crying. The newborn cry 24 hours a day and may develop acrocyanosis, and especially the newborn during the second or third week develop a superficial vesicle bolus lesion. The superficial vesicle bolus lesion are so severe and probably become infected with a Staphylococcus aureus, for example, and the patient may develop a sepsis and will die with this combination of the disease. In general, the newborn may develop thrombocytopenia and lymphopenia. Next slide, please. This is an example of newborn manifestation. We see the dermatological signs. Next slide. We see the severity of the disease. Next slide. Next slide. Next slide. And what's happened in the lab with the patient with chikungunya? It's not so useful to do the in a specific lab for found a chikungunya case. For lab diagnosis of chikungunya, you have to look for the virus. But in general, the patient may have a leukopenia with lymphopenia. Remember that in dengue, the patient may develop leukopenia with neutropenia. So neutropenia is present in dengue, lymphopenia is present in chikungunya patients. In dengue, we can find thrombocytopenia, but in generally, especially if the patient has a severe disease, the thrombocytopenia may be so severe. But in chikungunya, we can find the thrombocytopenia. And the segmentation rate is high in the patient with chikungunya, and C-reactive protein in general is positive as reagent in chikungunya patient, distinguished by in dengue. And sometimes the liver enzymes may be elevated and a mild elevation of CPK. Next slide, please. So, for the confirmation of the chikungunya disease, it's important to use the RT-PCR. And in the first day of the disease, the virus isolation may be positive, but of course we know that now the virus culture is not frequently used in the health system. It's very difficult to do this. So the reference laboratory do not do the virus isolation. So we have to use the molecular tests, and the molecular tests are positive or reagents during the first day of the disease, and the IgM probably may be negative. During the 5 day or more, the molecular test may be positive, the virus isolation may be negative, and the IgM may be positive. But remember that the IgM may be positive for month, of course, 1 year, 2 years, or 3 years. And after the day 8, the molecular test become negative, the virus isolation become negative, and IgM is positive. So if you see a patient in the day 10 of the disease, of course, we cannot collect the blood sample for RT-PCR, and you have to use IgM to confirm the case. Next slide, please. This is the PAHO, the Pan American Health Organization case definition. This case definition is used by the people that work at the epidemiological system. So, for epidemiological surveillance, they have to use the case definition. For us, that we are a doctor that care the patient in primary care, we can use, you have to use the case definition, of course, but sometimes if you use the case definition for a newborn, it's not positive, the case definition. So, when we have to suspect the chikungunya in a newborn, we have to suspect the chikungunya infection in a newborn if the mother had chikungunya during the labor phase. This is the why we can use the case definition. But the PAHO case definition for a suspected person, a suspected case definition is a person who lives in or has traveled in the last 2 weeks to an area with chikungunya transmission. Of course, the people from surveillance have to inform the health team where we can find the chikungunya transmission in Suriname. because if the patient do not live in a chikungunya transmission, it's almost impossible to develop the disease. And if the patient has fever combined with arthralgia or arthritis, and if we can't explain the symptoms using other diagnosis, this is a suspected case of chikungunya. A probable case of chikungunya is a case of chikungunya, suspected chikungunya case, that will have an IgM in a single cell sample, or if this patient has an epidemiological link with a confirmed case. And confirmed case of chikungunya is a case that we detect RNA by RT-PCR, or an increase in antibody titers and sample collected, two samples collected an interval from 2 or 3 weeks. But sometimes it's very difficult to recover the second blood sample. So it's important to use the molecular test. Next slide, please. In Brazil, we use IgM to confirm a case. It's a discussion between people from PAHO and people from Brazilian Ministry of Health, but we use the IgM to confirm a case. Next slide, please. And it's important to do the clinical classification of the cases, like we do the clinical classification for dengue patients. For dengue patients, we have dengue without warning signs, dengue with warning signs, and severe dengue. So the clinical manifestations, it's important to understand what's happening with the patient, because if the patient has abdominal pain in dengue during the effervescence of fever, it's a warning sign. So the clinical classification of this patient is dengue with warning signs. If the patient with dengue has only fever, arthralgia, and myalgia, this is a dengue without the warning signs. But if the patient develops shock, this is a severe dengue case. And how can we classify the clinical manifestation of chikungunya? If the patients have a failure of one organ, like an cardiac failure, kidney failure, respiratory failure, or if the patient with chikungunya needs to be admitted at a hospital, this is a severe case. Sometimes the patient may be admitted at the hospital if the comorbidity is complicated, like a high glycemia in a diabetic patient. So it's not just a severe case for chikungunya case, but it's severe because this patient has an important diabetes discompensation. And the other classification is a chikungunya with extraarticular manifestation. So if the patient develops a neurological, cardiovascular, dermatological, ophthalmological, hepatic manifestation of the patient. So if we see a patient with chikungunya, we have to look for the other manifestation. So sometimes we have to collect the blood samples to send to look for the liver function, the renal function, etc., and to look for the respiratory symptoms of the patient with chikungunya. Next slide, please. In Brazil, we use a typical or chikungunya case. We will not comment this. Next slide. And we have commented about the phase of chikungunya, the acute phase until 2 weeks, the post-acute phase after 2 weeks until the end of the third month. Next slide. The chronic after the day 90 of the disease. And in this phase, the chronic phase, we found only the joint involvement of joint manifestation of the patients. Next slide, please. Sometimes we can find a severe case like this, and this woman need a respiratory support during an important outbreak here in Natal. Next slide. This is the same patient, and you found the respiratory support for this patient was, of course, the respiratory failure. So, of course, it's a severe case. Next slide. The same case. Next slide. The oral lesions during the first week of the disease. So it's important to look for the oral lesion for the patients. Next slide. Rash. Next slide. Rash. The skin color alteration, it's important clinical manifestation of chikungunya, especially in the woman, because change the skin color. Next slide. And in young children, we can find a common manifestation. And so these young children under 1 year old, we can find the cardiogenic, distributive, or mixed shock, and we can find the risk of death in this patient. Next slide. This a small children with important high fever and irritability. We can see the face of the student with the irritability. Next slide. The same irritability of the student. Next slide.
We don't hear you anymore. I don't hear Dr. Luz anymore.
Okay, yeah, thank you. We are having a technical issue with Dr. Luz. We are going to fix it right now. Just give us a second. Clever, are you there with us? Clever, we can't hear your audio. I don't know if you can hear us.
I just called Clever. He is going to reconnect using his phone. He lost connection using his computer. So just
Okay,
a few moments, please.
thank you.
¿Me escucha?
Yes, we can hear you.
Okay. Oh, will you hear me? Thank you. We have a problem with the connection. So the skin eruption, next slide, please. And we can find the several manifestation in the newborns. Next slide. This looking for the facial edema and generalized rash in this newborn. You know that's so difficult to treat this patient. All the newborn with a chikungunya infection probably needs an intensive care unit. Next slide, please. The same problem. Next. Look the edema and erythema in these patients. Next slide. And the hyperalgic syndrome, these patients cry 24 hours a day. It's quite impossible to control the cry of the patient and the other symptoms of this patient. It's so difficult to treat this patient. Next slide. The red blood signs, it's sometimes frequent in the newborn patients. Next slide. The rash, next slide. So we will see a lot of pictures. Next slide, please. The hyperpigmentation at the end of the third or fourth week of the disease in the newborn. Next slide. Edema, next slide. The bullous lesion, next slide. And the epidermolysis is very difficult to treat. Last year, a newborn from Bolivia died with epidermolysis. It's so difficult to treat these patients. Next slide. Decamation, next slide. Cyanosis or shock, the patient may develop it. Next slide. And look for the nutritional evolution of this newborn. So the newborn was okay, nutritional okay status at the 2 days of the disease, and rapidly developed a nutritional compromise at the day 10 of the disease. Next slide, please. It's important to understand if it's possible to differentiate the clinical manifestation between the chikungunya, dengue, and Zika.
Hallo.
Next slide.
Midin van vergadering op bel u later.
¿Cómo?
You can continue, Clever. Thank you.
Someone has talked. It's possible to differentiate the clinical manifestation. Next slide. So, if the patient has rash, conjunctivitis, arthralgia, myalgia, or bone pain, it's probably that this patient may have a arbovirus disease. We cannot use this to differentiate dengue from chikungunya and Zika, but it's important to look for rash, conjunctivitis, arthralgia, and myalgia. Of course, we will comment sometimes about the differential diagnosis at the end of the presentation. And the lab, if in the lab we found decrease in platelet count, we is closer to dengue. But especially if you found a hemoconcentration, so the hematocrit increase during the disease, probably this may be a dengue disease. In leukopenia in dengue, headache in dengue, and pruritus in Zika. But if you can use the retroorbital pen, it's low certain. And this was found in a special revision of the literature, and the PAHO used a lot of publication about the arbovirus and found this to use for the clinician how to differentiate between arbovirus disease from other febrile disease. Next slide, please. And if you can use for differentiate between dengue, chikungunya, and Zika, and with high certainty, we can use lab for differentiate between dengue and chikungunya. But if the patient has arthralgia, probably we are in front of chikungunya disease. But if the patient has pruritus, probably is a Zika manifestation. So it's important for all clinicians to use this table to use the clinical science or lab science to do the differential diagnosis between the arbovirus disease. Next. Let's comment about a case from last year in 2025. It's a 64-year-old woman that lives in Pipa. Pipa is a beach in Rio Grande do Norte state that developed high fever, headache, neck pain, joint pain, and she has diabetes. And she meets the medical care at the health unit and was prescribed analgesic but developed a poor clinical response. So what's happened with this woman? If the woman has fever, headache, neck pain, and joint pain, probably she had chikungunya, because chikungunya is the arboviral disease that the patient developed joint pain, and the joint pain is important. And if the patient has diabetes, it's important for the diabetic disease in this woman. Next slide. Look this patient in the acute phase, the joint edema, a lot of joint edema, polyarthralgia. Next slide. And you can see in the lab test, the hematocrit is normal. So in dengue, we can find an increase in hematocrit, and the white cells was normal, and the differential white cells was normal, and the platelet count was 221,000. So it's normal. So probably this patient has not dengue, and she had chikungunya disease. Next slide. And the diabetes was not controlled. Next slide. And 30 days after the beginning of the disease, we can find the edema in the joints. So this patient now is in the post-acute phase, and she had an important joint pain. And you have to treat these joint pains with analgesic and anti-inflammatory drugs. Next slide. So we look for the IgG was negative. Next slide. And the chikungunya IgM was positive. So when this woman came for the Tropical Institute, Medicine Tropical Institute, it's not possible to collect the blood sample for molecular tests. So we use serology to confirm this diagnosis. Next slide. And the IgM was not concluded. Next slide. And this is other woman that developed chikungunya. Diego, please go ahead, because go ahead, go. Okay, so how can you do the clinical management of the patient with chikungunya? Of course, depends on the phase of the disease. So it's important to understand where is the patient, acute, post-acute, or chronic disease. Depends on the intensity of the clinical response. Some patients requires close monitoring, especially the newborns, the children under 1 year old, and the old people. The majority of cases that have evolution for death are included in this group of the patients: newborns, old people, and children under 1 year old. And it's important to understand when refer the patient for a hospital. If it's a pregnant woman with chikungunya, she needs to be referred for a hospital. Next slide, please. You have to understand the phase, use the clinical case definition, look for extraarticular manifestation. We have to do a complete physical examination of the patients, look for myocarditis, pericarditis, heart failure, for example. We have to look the respiratory system, because some patients have respiratory failure, pulmonary edema, for example. We have to understand the nervous system of the patients and look for encephalitis, meningoencephalitis, Guillain-Barré syndrome, for example. And we have to look for the kidney function. So the patient with chikungunya is more complex than patient with dengue. And of course, if the patient has a severe chikungunya, what is severe chikungunya? Is when we found an organ failure in the patient, a respiratory failure, a cardiac failure, a postural hypotension, for example, or hemorrhagic manifestation, for example. And all the patients with severe disease have to be referred to a hospital. Next slide. So If the patient is without extra-articular manifestation, the patient has only chikungunya, fever, and joint pains, no signs of severity of the disease, this patient may be followed like an outpatient patient and have to have a new other visits to the medical care. But if the patient is from a risk group or the patient has an extra-articular manifestation, this patient probably may have to stay in a closed observation until the resolution of the clinical signs, especially until the results of the blood test, because you have to do blood tests for the patient. I will repeat, newborns, children under 1 year old, patients with comorbidities, and the old patients. Of course, if the patient has a severe sign of the disease, this patient have to be admitted in the hospital and sometimes in intensive care unit. Next slide. We have to use the visual analog scale to understand and to ask the patient about the severity of the pain. We have to ask the patient to understand if the pain is better or if the pain has worsened in the last day. Next slide. So, if the patient is in acute phase, we have to use, I don't know if Diperon is using in Suriname, but in Brazil we use a lot. We have tablets of 500 milligrams, and we have to use one tablet each 6 hours for treating the fever or the joint of the patient. If the patient is allergic to Diperon, we can use paracetamol at the same dose. And for children, we can use 10 milligrams per kilo for treating the fever or the aches in this patient. In general, we can control the fever and the joint pain using Diperon or paracetamol. Remember that during the first week of the disease, it's important to think in dengue. So we have to use only these two drugs to control the fever and the pain during the first week. During the second or third week, you can use other drugs. Next slide, please. If we can't control the pain using Diperon or paracetamol during the acute phase, we can use codeine or tramadol to control the joint pains. But we have to use carefully, especially in the old patients, because we can have effects that can complicate the case with chikungunya. But sometimes we have to use this. So the health system have to put this medication at the primary care. For the primary care doctors, use codeine or tramadol for the patient with chikungunya. Next slide, please. After the acute phase, only after the acute phase, we can use the anti-inflammatory drugs like ibuprofen or naproxen in the usual doses to treat the joint pains of the patient. We have to use the ibuprofen, for example, for 7 days or 10 days, not more than this. In general, the patient responds to use to recommendation of ibuprofen. Next slide, please. It's not frequent, but sometimes we have to use corticosteroid to treat the arthralgia of this patient. We have to use corticosteroids in the low dose possible and only during 5 to 7 days. We use to 1 week. close the use, and if the patient worsens the joint pains, we can use again for 7 days, not continuously. We use only for a week and 20 milligrams by day, for example. Next slide. During the chronic phase, we cannot use anti-inflammatory drugs or dipyridamole, paracetamol, or acetaminophen. Probably to control the joint pains during the chronic phase, we have to use hydroxychloroquine or methotrexate. I think, in my opinion, methotrexate is the most effective drug to control the pains during the chronic phase. In January, we use 3 tablets once weekly, 7.5 milligrams on the week, and for a month, 2 or 3 months. And at the end of 3 months, we can end the use of methotrexate to treat this patient. It's important to distinguish between inflammatory pain or neuropathic pain. If the patient has a neuropathic pain, we have to use gabapentina or amitriptyline to control this pain. So it's important during the consultation to distinguish between inflammatory pain or a neuropathic pain. Next slide, please. Okay, go ahead. Next slide, please. Next. Go ahead. Next. Okay, just a comment about the vaccines, chikungunya vaccine. We have a live attenuate vaccine that's not used for now because the FDA stopped the use of live attenuate vaccine, and only the other vaccine is used for the patients for prophylaxis, chikungunya prophylaxis. But in Brazil, do not use the chikungunya vaccine. We have some sites that are beginning some clinical trial to use the chikungunya vaccine, and vaccine was used, live attenuate vaccine was used in Isla Reunion, and some patients died after the use of live attenuate vaccine. So the live attenuate is not more used in the country. Next slide. Next slide. Okay, so in summary, we have to establish the diagnosis of chikungunya. The diagnosis is the name of the disease that explains the signal and symptoms of the disease. It's important to determine the severity of the disease, because the severity of the disease informs to the patient and for the health team where the patients must have been treated, like an outpatient or a hospitalized patient. It is important to determine the need for complementary diagnostic for evaluation, especially for comorbidity of the patient, and establish the clinical management of the patient, like an outpatient, a hospital-based patient. And it's important to ensure the follow-up of all the patients. All the patients have to have access to the health system to receive a medical consultation, especially if the patient developing a severe disease. Next slide. And thank you, and thank you. Thank you so much for the opportunity to discuss with you about chikungunya.
Thank you so much, Dr. Luz, for a very comprehensive and practical presentation. And we will now move into the question and answer section, moderated by Dr. Diego Campos from Bajo. Dr. Diego, floor is yours for the Q&A.
Thank you, Jamin. Just give me a couple of I'm just arranging my my desktop because I have multiple windows open for the chat, the microphones and everything. So I'm gonna read the questions that you sent. Feel free to send your questions also in Dutch. We are making some translations so we can read them to Dr. Luz. And I'm going to start with the one of the first questions. Dr. Luz, uh, can one be infected with dengue and chikungunya at the same time?
It's possible, but in general, the clinical manifestation is caused by one virus. If you take the blood sample and send to the lab, it's not frequent where the result reveals
We can't hear him anymore, and we
Okay.
hear echo.
Clever,
dengue and chikungunya virus.
sorry, Clever, we lost you a couple of minutes. Can you repeat your answer, please?
The question is, sometimes the patient may become infected with two viruses, dengue and chikungunya. And if you collect the blood sample and send to the lab will inform you that the patient has two viremia. But in generally, the clinical manifestation is from one virus because the other virus is suppressed. So the patient may have chikungunya with fever, joint pain, etc., and or dengue. The patient doesn't develop two diseases at the same time. It's almost impossible to see a patient with varicella and measles. The patient may develop only one disease, not two diseases at the same time. Of course, we are not talking about the patient with AIDS disease.
Okay, we have three similar questions, Clever, and it's about if we got chikungunya in the previous outbreak, can we get chikungunya again?
No, in dengue we have 4 serotypes, so we can be infected 1 time, 2 times, 3 times, and 4 times. But for chikungunya, we have a different genotype, but serotype is only one. So the patient become infected with chikungunya only 1 time in the life. It's probably impossible to become infected other time.
How about the laboratory test and biomarkers that you mentioned? They question, does it mean that it's not necessary to check immunoglobulin G after the fourth or fifth day, or only IgM?
Only IgM. Only IgM. The question is, if you do the medical consultation for a patient with joint pains, and the patient do not refer fever, and inform the doctor that had chikungunya 12 months ago, but didn't do the no lab for chikungunya. So you have to know if the patient had or not chikungunya to treat the joint pains. So you have a blood sample to send to IgG to inform you that this patient had chikungunya 1 year ago. It's the utility of IgG. So you have to use molecular test or IgM. The IgG is not useful to manage the patient during acute phase.
Related to your last answer, Clever, they ask us if we have which one is the fastest to get more accuracy on our diagnosis.
Sorry, I don't understand it. Could you repeat the last?
Which one is the most accurate test that we can perform to the patient?
Molecular test. Molecular test is the most accurate. In general, the patient with chikungunya during the first until the second week have a molecular positive test.
Okay. There are a couple of questions related with pregnant women. You said on your presentation that all the pregnant women have to be hospitalized, but they ask what we have to monitor daily in their vitals or in their signs.
Okay. let me clarify the information. If you have a pregnant woman close to the labor day, I think that's better to admit this woman in the hospital to monitorize the clinical manifestation and the newborn. Not if the pregnant is in the first trimester of pregnancy and develop chikungunya, probably this pregnant woman does not need to be admitted. It's different from dengue. In dengue, all the pregnant women have to be admitted in the hospital, independently from the period of the pregnancy. Okay, because in the labor, the newborn become infected, and you have to monitorize because pregnancy is a comorbidity if the patient has chikungunya. So have to monitorize it, especially if the pregnant woman lives far from the health system. Is what's happened in a lot of cities in South America. We have big countries, and Suriname is a small country compared to Brazil, but it's a big country compared with the countries from the Central America, for example.
And also, who is going to lead or who is supposed to be in charge of the monitor of the pregnant woman? The gynecologist, an internal medicine doctor, a general doctor?
The best doctor to follow a pregnant woman is gynecology. So the gynecologist from Suriname must be training in chikungunya management. Of course, if the pregnant woman develops hypotension, for example, shock, she needs an intensive care unit, and the people from intensive care unit have to manage this pregnant woman, because it's important to understand what's happening with the newborn and with the pregnancy. So I think, in my opinion, the best doctor to follow a pregnant woman with chikungunya is a gynecologist. Of course, they have to have a reference, a clinical, to discuss the case, an infectologist to discuss the case, of course. But because the complication of pregnancy is close to the gynecology activity.
Okay, just to clarify this about the when you hospitalize a patient is when she's close to the labor, when she's close to labor, right?
I think. Not all
Okay.
the pregnant women needs to be admitted.
Okay, and now link it with the newborn. Do you have any data or you can share us any idea of the mortality rate in newborns?
I don't have the fatality rate in the newborn, but it's high. It's high. If the newborn develops chikungunya during the newborn period, is high the possibility of complication death, because it's a normal newborn.
Okay. During your presentation, to be specific, you mentioned a ragdoll sign, like a rubber doll sign. Can you explain a little bit more about this sign? Sorry.
I have to change my cell phone because I have problem with the. Do you see me? Do you?
Yeah, it's okay.
So the sign is like this. The newborn is like this. You put the arms like this, and they come back with the arms to the trunk. Okay, this is the sign of the newborns may develop with chikungunya. Remember that in tetanus, newborn tetanus, the newborn is like a boxer, no? Boxer sign. But in chikungunya, it's like this. We put the arms up and go back to the trunk. This is the sign.
Okay, we are going to talk about treatment. One of the first questions related with conjunctivitis is some patients say that they have irritating symptoms, tearing, itching. What can be given to subside these symptoms? Corticosteroids, eye drops, such as dexamethasone can be used?
No. In general, the conjunctivitis in chikungunya, we do not need to use any medication. No medication is necessary. Only physiological drops in the eyes, not the corticosteroids. It's not useful to treat this. It's asymptomatic conjunctivitis.
Okay. Related with the itching, any antihistamine medicine that we can give them?
In general, the itching during an arbovirus disease like Zika, dengue, or chikungunya is pharmacoresistant. But sometimes we have to use antihistaminics to help to control. But it's better to wait 2 or 3 days and the pruritus will finish. Sometimes we use here ice over the skin, and we can control the itching. But it's most important to explain the patient. Please wait 2 or 3 days, and the pruritus will finish.
Yeah, we have a comment about this, right? That about the communication to the patients should be clear about the symptoms, the wide range of symptoms, and also related with the mosquito transmission, no? That all the caution that they have to have with the mosquito bites. These were all the questions related with clinical management. Clever, we thank you so much for your time and your excellent presentation. If you just give me the 1 minute, I want to share. I don't know if you are seeing my screen right now. I don't know if you can see my screen in this moment.
Not yet.
Now?
No. Now we are seeing.
Now, so
Yes.
we want to share with all of you the PAHO's Chikungunya Clinical Management Guidance documents that are published in our website. You can access them by scanning the QR code, where all the clinical guidelines that Clever mentioned during his presentation are published, and you can have them you can download the documents and use them in the clinical settings that you are cited. This is all for me. I give it the floor back to you.
Thank you so much. And there are some questions that we will make presentation available to all the participants, so it will be shared. And again, I'd like to say thank you for joining us and the colleagues from Ministry of Health, BOG, and from PAHO, our office, speaker, moderators, and all the participants for this time and valuable discussion. PAHO remains committed to supporting Suriname with evidence-based guidance, hands-on technical assistance, and regional collaboration during the outbreak and beyond. We encourage clinicians to apply today's guidance in practice and to remain engaged with ongoing response. Thank you so much.
Thank you very much.
Thank you. Bye-bye.
Thank you.
Bye.